Welcome to the latest edition of the All in Skills podcast. This week, it is my pleasure to welcome Dr. David Ungar to the studio. Hello, David. How are you?
Hi, Colin. I'm very well, thanks. Bit chilly, but all is good.
David is a fellow Melburnian, so we're both suffering under the same cold winter regime.
Exactly. So thank you for having me on the program, Colin.
It's my pleasure. David, for all of the people who are joining us, tell us who you are and what it is that you do or did.
So, Colin, my name's David Ungar. I've been a general practitioner for the last 40 years. I was born in Melbourne, went to school in Melbourne, and went straight from school into university studies at Melbourne Uni to do my medical course. There was no gap year, there were no undergraduate requirements. We just went straight from school as fairly naive 17, 18-year-olds into medical training. And in those days, medical school was a lot like high school. You'd go to lectures as a big group and sit your exams as a group. It was a lot of rote learning and repetition.
You stated it was almost matter of fact. I finished high school and I went to do medicine. Was there any pressure on you to make a choice about studying medicine, or was it something you'd always wanted to do?
Well, interestingly, when we had to make career choices and decide what path we would do after school, I really had no idea. And I think the majority of my colleagues, there were about 10 other students from my high school who went on to study medicine at uni. Most of us had no real idea of what we wanted to be, in inverted commas, when we grew up. Medicine offered us the widest choice of careers with a bit of status and a guaranteed income. I was always interested in people, in their character, in their nature, and in their reasons for making choices and dealing with positive and negative choices that they made. So I was always interested in that side of the personality, but I did not study biology at school. I did not enjoy blood or guts, or there were hardly any TV programs. I did have an aunt who was a doctor, who was pretty influential, but the truth of it is that my parents actually discouraged me from doing medicine because they knew how consuming that sort of career could be.
Also breeze past this idea in your opening comments about no gap year. Was it a common thing at that time to take gap years or not?
It was very unusual. There would have been maybe 1 or 2 out of the 100 kids at school who took a gap year. Most of us went straight from school to uni.
Is that something you think about or regret, or it's just something you accept?
It's something I accept. Looking back and looking at my son, who's now finished his medical training, I think doing an undergraduate course first, a general arts or science course, would have given us a bit more perspective and a bit more clarity on the type of medicine we wanted to be part of, the medicine we wanted to practice. Those sorts of decisions came to us, I think, a bit later, and we could have been better prepared had we had a bit more life experience before starting.
And was there any kind of career guidance at school at that stage, or were you?
No, this was in the 70s, and you really got into the course that your marks gave you. There was no interview, there was no career guidance or aptitude testing. You just got the marks and you applied and got accepted, basically.
And at that time in Melbourne, how many medical degrees were there on offer in this state? Do you know?
There were the 2 colleges, Melbourne Uni and Monash, were the only 2 universities. Melbourne had, I think, about 220, and Monash, I think, around 150 students.
And has that changed over time?
There are many more universities now that train doctors, some, and especially in country settings. And, of course, the requirements to start your training are totally different. There's the aptitude and the interviews, there's the undergraduate requirements. But people coming from diverse backgrounds in industry or in other allied health careers, a very wide selection of people and personalities now.
So let's just return to your own journey. You're at Melbourne, is that right?
Yes, yes, yeah.
So you're at Melbourne, and in this cohort of people, did you have this kind of diversity at that time, or was that not the
No,
case?
no. At that time, we were probably 2/3 male, 1/3 female students. Almost all of us came from private high schools, and 90% had come directly from school. A few had taken a gap year, a few had come in from other careers, pharmacy, or I think we may have had one or two nurses, but really we were a pretty homogenous bunch.
And in terms of your experience of the course, the teaching, do you have any recollections of being either impressed or underwhelmed?
I found it very underwhelming. It was very much rote learning, a lot of basic science, physics, chemistry, biology that most of us found irrelevant. The anatomy was just masses of detail to memorize and then recite at the exams. The first 3 years were a slog, but that's what we were used to through high school as well. I think we had 2 weeks of general practice exposure in the 3 years, but really that was the only time we saw living people, living patients.
How did that work at the time, the general
There
practice?
was a nominal program of talking about general practice as a career, but really it was very downgraded because the intention was that people would go on to specialise in something. However, they put in this theoretical training about general practice and then sent us off in pairs or in groups to larger clinics for 2 weeks of sort of training to see what a general practitioner did. This was suburban practices, but we were observing. We didn't really talk to patients. We didn't really examine patients at that stage. We were tagging along, and the feeling was that the general practice exposure was a condescension. It wasn't to be taken seriously.
At what point did people start to think about specializations?
Well, that really wasn't until the 4th year when we'd started our hospital-based training. And then really there was, once we were in that system, there was minimal experience of general practice, but in a way also general practitioners were kind of downgraded as either not knowing enough, not being confident enough, not being skilled enough, and really patient care was best managed by specialists. I mean, GPs did coughs and colds and, repeat prescriptions, but the skill levels of a general practitioner were pretty much downgraded.
Was there at all this sort of mercenary thought of, I want a specialization that's going to make me the most money? What were the considerations or conversations you were having then?
No, I think it was really a consideration of prestige and of status and of respect that prompted the specialists. It was more a collegial hierarchy rather than making a lot of money. The surgeons were certainly the ones who seemed to be making the most money, leading the most affluent lifestyle in terms of holidays, recreation. But I think everyone felt so busy, so much time working, whether it was patient contact, research, meetings. The money side of things didn't really come into it. Our teachers were by and large salaried hospital employees.
And when did you make your choice?
Well, after the hospital-based training, I really wasn't passionate about limiting my patient care to one group. I enjoyed a lot of pediatrics. There was parts of psychiatry I enjoyed. I enjoyed internal medicine. I enjoyed some of the simple surgical procedures, some suturing, some plastering. If the people who chose to specialise really lost a lot of that interesting sidelines. I suppose I wasn't as research focused. I was much more interested in the people side of work rather than the laboratory side. And it was kind of taught to us that research was the way to go, the way to get published, the way to get recognition. And so after my intern year, which I found very, very demanding, very difficult, I started looking at general practice, both as a lifestyle, but also as a way of just getting the most experience, the most interesting, varied lifestyle to work life.
In terms of mentorship, people that you could talk to have these kind of conversations about your preferences, your proclivities, the things that you wanted to avoid. Like you weren't so into the research side, you wanted a more human aspect. Were there people around? Were there people available to have those conversations with, or were you left again to your own devices to make those choices?
We were largely left to our own devices. The hospital system was focused on specialist training. If you weren't cut out to be a specialist, they really didn't want to know you at that stage. Once I joined the general practice training, there was a little bit more interest in developing people's, I guess, skills and confidence in managing, in adjusting to general practice. But it was more of a chat, more of a formality, a bit of a tick-the-box interview. At that stage, you were left to get through it on your own, to make your own way, basically.
In my previous work, I worked a lot with people who were preparing to practice medicine in this country. Something which came up quite a lot was on the speaking side, we had to do 5-minute simulation conversations, typically between doctor and patient. It's interesting how little preparation people had for those encounters, for those conversations. I'm curious, how much of that sort of bedside manner was taught to you?
So, interestingly, zero. And even the exposure we had as students to general practice, the patients we sat in with were straightforward cases. You've got a cough, you've got a cold, you've got a pain here or a symptom there. And it could have been just the setting, that there were 2 strangers observing in the room, but there was nothing. One of my careers after I had during a break from general practice was actually at the college, with the College of GPs in their teaching program, in their training program. And there we did a lot of work with communication. We had simulated patients, we had direct observations, we had cameras in some of the consulting rooms, and would discuss the consultations either in small groups or one-to-one. And the focus was completely different. And that was about in the 90s. Now, we're talking 25 years later.
By which time you were very well established in your career.
I was in my career and I was doing teaching, and the approach to training GPs was different too.
You previously mentioned surgeons. Fortunately, I suppose my contact with surgeons has been relatively minimal, but they do have a reputation for being quite cold. Is that true, talking about communication?
That used to be 100% true. You would go to a surgeon, to have something fixed. But, it's interesting. The younger surgeons are much more, are often less keen to operate, more keen to to discuss the different approaches one could take to managing a condition. Obviously, emergencies are different and fractures are pretty straightforward, but there's a lot more individual care nowadays. Surgery used to be pretty much follow the instruction manual. You've got your gallbladder needs to come out. Well, we'll just hook you in and do it, and off you go. Nowadays, there's few differences.
Let's go back to your path into general practice then. What came next? You had your internship, and then you made your decision about general practice?
I did a second year at another general metropolitan hospital, and then really I went into general practice training. So at that time there was a family medicine program, and they arranged hospital rotations to get more specialist experience, deeper levels of experience. Then we had students, and also a 3-month or 6-month rotation into a general practice. I went into a general practice at Ungar, which was an excellent practice and a very good group practice in many ways. Again, the role models of, I never intended to do rural general practice myself. I was always going to be a metropolitan GP. And these rural GPs, even though Leongatha was only 3 hours away, these rural GPs still did everything. They did surgery, they did obstetrics, they did anaesthetics, they did assisting. They were available 24 hours a day. They were on rosters, and they would do home visits sometimes to farms an hour away. And the mental image of the GP, the role model that I had in mind, the image that I got from our family GP was of a solo GP who really could do anything and would do anything and was available for his patients all the time. And kind of that was reinforced in my rotation to that group in Leongatha. The positive sides of the group in terms of having time off, having holidays, having breaks, being able to take a break during the day, that also rubbed off on me. Even though most of my exposure to GPs in Melbourne were GPs who worked solo, GPs who were either on their own or had an assistant 1 day a week. And I had very good hospital experience and went out into general practice probably in about 1984, doing locum work at first. And again, most of my locum work was in solo practices. The advantage of that was you could see how closely involved with each family, with each patient, the practice and the GP was. Families trusted the GP. The GP wasn't just a technician, the plumber, the mechanic. He was really a valued member of the family and also the local community. And in fact, I was looking to join a group, but no opportunities came up, and I ended up actually taking over a solo practice in a very nice metropolitan area. And that's where problems began.
So how did that come about?
Well, at that stage, there were a couple of medical agents, it was called, like real estate agents who dealt with medical practices, buying and selling practices or buying and selling partnerships or memberships of a group practice. And you would tell these people, look, I'm looking for this style of practice. I want to join this type of group or this area. I want to work in this area. And they would come up with a list of practices for sale, GPs retiring or just selling or whatever, and say, try it out, go for an interview, see what you think. Locum work was okay, but I was getting a bit sick of it because there was no continuity. You'd go to a place for 2 or 3 weeks, enjoy the work, do well, and then move on to somewhere else. A few places you might go back to 6 months' time when the doctor wanted a holiday or whatever reason. So I went for a few interviews and I didn't get into a number of groups. We were expecting our first child at that time. So there was a little bit of pressure to settle down and start a more stable career. And this solo practice came up it was actually in East Malvern, and the premises were good. The patient profile was okay. Receptionist was going to stay on. There was an assistant who would stay on, I think, 1 half day a week. And so a little bit reluctantly, because it was solo and not a group, I took it on. And then I got caught up in the workload, really. The expectations that a solo GP would be available, that a good GP was there for his patients, and your own needs and family requirements would come second. And that was okay for a few years. We had 1 child and my wife stayed at home, was able to be a stay-at-home mother. We had another child and that was okay. Work was going well, but the hours were extending. I was still doing my own after hours most of the time. I did take a couple of holidays. I had 1 assistant doing 2 half days, but when our 3rd child came, I started feeling that I was missing out on family life, that there was a lot more going on beyond my consulting room that I was missing out on. And gradually that feeling increased, and I think I experienced what nowadays people would call burnout. I did not enjoy the work. I started resenting having to go to work. I was tired. I was not enjoying family life as much as I should have. And there was no one really to talk to about that. Counsellors, psychologists who specialise in sort of work-related traumas and burnout were not around.
How long had you been in solo practice at that point?
That was about 6 years. 6 years on my own.
So what was the solution? What was the way out?
Well, what I did was I looked for and I found an associate, someone I thought would be a partner in the practice, and I could share the workload. That didn't quite work out as I imagined, and I ended up leaving the practice to him, and the family and I went off to the Northern Territory for a career change.
How old were your kids at this point?
So the oldest was 7, middle one was 5, and the youngest was 3. The kids the older 2 went to school, to the state school. I had a fantastic time. It was a completely different work environment. Again, I was not working solo. I was with a group of very talented doctors, hospital specialists who could do anything. And there was a GP clinic in the town with some amazing practitioners there who had been there for years and could do everything through all sorts of disasters and catastrophes.
How long did you stay there for?
6 months.
And did that do the necessary recharge for you?
Well, it did. I felt much more energized. Unfortunately, it didn't do anything for my marriage, and so I ended up getting divorced, and that was not good. That was not good.
So with the end of your marriage, did that mean you left Catherine?
Yes. Coming back to Melbourne, I wasn't ready to go back into general practice. And that's when I started working with the College of General Practitioners training program at that time. And again, that was with a group of other doctors. We would talk a lot about how we were doing. Again, building confidence in a new career, in something that was really quite a challenge to most of us. None of us had had experience as teachers before. And that was really quite an educational 3 years of work.
And doing that, you were able to make ends meet just in terms of progressing your career, which of course is front of mind. You're still a relatively young man.
We had to do a day a week of practical general practice. And I found a practice that had quite a different patient clientele. We dealt with patients with drug addiction. We dealt with patients who had HIV. And a few normal general practice patients as well. There was a point where I was ready to go back into full-time general practice and leave the training program. And so that was after about 3 years. I was in a better state of mind. And again, this was a group practice with some experienced doctors, some more junior doctors, but good secretarial and supportive staff, and I went back into full-time general practice, really feeling quite ready.
And with a completely fresh mindset.
A fresh mindset, but ready again to learn some new skills.
Were there any particularly interesting new skills that you were putting into practice at that point?
Well, addiction medicine was sort of becoming a little bit more widespread, widely known and acceptable, but it required a different mindset to your normal general practice patient. A patient with an addiction will not tell you the truth. The patient with an addiction just wants drugs, and they don't want to be your friend. They don't want to trust you. It's a different relationship completely. And I learned to be firm. I learned to say no. I learned to stand up. I learned to protect myself in case of physical threats. Although the goals were very limited, there were many times we could prevent complete breakdown of people's lives through drug addiction. We could control their addictions to some extent.
Was there a wider effort on the part of local, state, federal government to actually do something about this problem?
No, no, no. The police were enforcing prohibition as much as they could, but detoxification and counselling services were very limited. In fact, no, they were only private facilities with long waiting lists.
And is that something that's now improved, changed?
Not really. The nature of the drug addiction has changed. So we would see people with heroin or cannabis dependency, maybe benzodiazepine dependency. Violence wasn't common. Yes, they would fight among themselves for drugs or money, but they didn't really often attack or steal from the doctors. It did happen, of course, but nowadays with the amphetamines and the synthetic drugs and all the violence, there's such an increased level of violence. The violence has got much more intense and severe. I think the whole area is a lot more frightening, and there isn't really a detoxification for that.
You mentioned earlier that your son has entered medicine.
Yes, yes.
Was there paternal input on that? Was that a choice he made independent of you?
Yes. So I remarried, I repartnered, and we have 2 children in my second marriage. My second wife is also a doctor, specialist in geriatrics. And again, through school, my son had no real interest in medicine. And even at uni, his undergraduate course was really looking at physics and maths and a few broader subjects. Medicine was not prominent. I think toward the end of his undergraduate course, he saw that we could have a lifestyle and a work pattern that was rewarding and not too exhausting. I had changed my work priorities after my divorce, and I think that was an improvement in my own approach. And my wife is a hospital-based specialist, so her lifestyle as a consultant, as a senior consultant, was also gave her time for other interests and just to stay well. And I think that's been an attraction for my son. He also has a strong interest in people and their personalities and their motivations, more than just the science, and he certainly doesn't like surgery. So he may go into something like geriatrics, which is pretty close to general practice, actually. But it's probably the broadest of all the specialties.
Of course, your son made his choice, but speaking more broadly, if you're looking at the state of health services in this city and in this state, do you think that it's a time of opportunity or a time of challenge?
It's interesting. I think medicine is still a great career, but what I think has changed is the attitude of younger doctors. Certainly there's a group who are keen to make money, pay off their debts, and enjoy a good lifestyle. But there's also a significant number of people who want to do general practice and want to enjoy personal time away from work to pursue family or other interests. And so this idea that you're valued by the amount of hours you put into work, that has changed enormously. People will come in, do their hours, have their breaks, go home, and then no one is working 7 days a week anymore, or it's very rare to work 7 days a week. Even within the hospital system, the hours of the doctors in training has dropped dramatically. I personally had dreadful experiences coping with 2 or 3 nights in a row, being on call for a weekend, starting on Friday and ending on Monday afternoon. I found that very exhausting and traumatic, actually. And I think, even though nobody really talks about this and there are no real numbers, but I suspect that the numbers of young doctors committing suicide has dropped.
Do they now have those support structures? You mentioned at no real point, you needed people to talk to consult, to counsel, and you weren't finding them. Has that changed?
That's changed enormously. The specialists are much more approachable. The teachers in hospitals are much more sensitive to their students. And I think it's required that they talk to their doctors in training regularly about how they're going, review their progress, but not in a threatening way. If you weren't up to standard that your specialist wanted, your consultant wanted, they would let you know that you were not worth the effort. Nowadays, it's a completely different system. Much more support. People are offered time off. You would never take time off. You'd go in, you'd have a flu, you'd have the cold, you'd be spluttering and nauseated. But you went in. People are looking after themselves much more and looking for help. It's much more acceptable to ask for help and to say you're not coping with this, or you've got other things going on in your life and that's making work difficult. There's much more support and understanding of people's individual needs.
If you were back in your third year of studies in higher education and making that choice today about where to specialize, would you make the same choice about general practice, or would you think about something else?
No, I'd love general practice, really, to see, first of all, you've got so many opportunities. I've had little special interests in my career. You're able to take your degree and your experience interstate without any problem. I did teaching, I did general practice, I did some special interests in general practice. No, it's a wonderful career. Yes, your patients get older with you, so as you get older, you see fewer children or fewer teenagers. It's not such a bad thing. And you develop knowledge and skills in older people's medicine. The learning is always there, and the patient contact. I think the big difference, and really something I would advise younger doctors, is to join a group. Make sure you have time for yourself, for interests, whether they're in developing skills and expertise in certain areas of medicine, or whether you just want to develop outside interests, bushwalking, music, language, whatever. Maintaining and developing interests, and include your partner in as many activities as you can outside of work. Don't forget your family needs you too, and you need to be around and in a good state of mind.
Dr. David Ungar, you've been a wonderful guest. Thank you so much for your time.
Thank you, Colin. Thanks.